All right, you guys, day 2 of Case Roundups. Again, just as a reminder, this is the historic Mac Harmon and Todd Ponsky show that we have turned into 3 sessions that rounds up every single day. And today, we are going to start with an esophageal foreign body. So first question, here's your x-ray. This was a witnessed ingestion 1 hour ago. Are you getting any more imaging before you go to the operating room? Does it look like it's working on the pulls? Everybody pulling in? All right, here we go. Interesting. So 1 hour ago, ingested, witnessed ingestion, came right to the hospital from home. About 40% are going to get more imaging than an x-ray. Looks like about 60% going to the OR. Let's hear who wants more imaging. Raise your hand if you want more imaging. Scaife, what do you want? Okay. So I think Dr. Scaife here is saying you can't tell if it's a button battery or if it's a coin. Is that okay? Regan agrees? Yeah, we got someone here.
I want a plain film of the abdomen and pelvis to make sure this troll didn't swallow anything else.
All right. So we got a side view x-ray. We got an x-ray of the abdomen. Anybody else want something?
Yeah, I would get lateral just to see whether it's in the airway or in the esophagus.
I couldn't hear that. Brian, will you repeat?
Yeah, I said get a lateral x-ray to make sure that it's in the, to check if it's in the airway or the esophagus.
So, a button battery. All right, next. So here we go. Are we going to give antibiotics before we take this thing out? So you're in the OR. Are we going to give antibiotics? Yes or no? Okay, that's pretty no controversy. Looks like we are not giving antibiotics. What about this? Now, same case, witnessed. It is a button battery. We're 3 hours away. You get the call. Somehow the ER calls you and you're talking to the mom. Is there anything that you can give while they are en route? Awesome. So we had a great presentation earlier today, so I think everybody got it. But just as a reminder, these are the exact recommendations. So we give honey, and you can see the dosing there. And then, like was mentioned earlier today, if the kid's less than 1, we still can't give honey, so you can go ahead and give Carafate. So what about, they have no idea. Like, the kid's kind of been having a hard time eating for 6 weeks. It looks, you got the side view, it does look like it's a button battery. Is there any other imaging you're gonna get now before you go to the operating room? So we think this thing's been in there for weeks. I'm seeing some nods. Let's see what the poll says. So pretty convincing. Does someone that wants to get more imaging, let's hear. Mac, you got anybody over there that wants to make a comment?
I got one here.
Yeah, I want to know about that esophagus and its relationship to the aorta, if that's been in for a long time. I'm worried about a lot of bleeding. Yeah, CTA, that's what I would get.
We got a CTA from Dr. Neff. Anyone else? Anything different? How about the people that said no? Anyone want to defend that? I can't hear. Oh, sternal saw. So have a sternal saw available. No more imaging, just be ready. Do you guys talk to your cardiac surgeons before you go ahead with a kid like this that's been in for 6 weeks? Dr. Henry? Yeah? So tray ready, big IVs, like ready to go just in case something's gonna happen. Come on guys, we gotta fire up this crowd. Anybody else, comments? Yeah.
I'd grab a balloon, an esophageal balloon, just in case you get torrential bleeding, you can blow it up and put some tamponade there.
Great. Esophageal balloon? Yeah.
They've come a far way with endovascular techniques as well, and so if the CT scan suggests that it's eroding partially through the wall of the arch or the innominate, maybe they can put a stent there or be ready with a balloon, so when you do pull on it, the patient doesn't, exsanguinate. And then if you're planning a sternotomy, at least if you kind of know where it might be, I think pre-op imaging in this setting is definitely helpful.
All right, so now this is the same kid. So it's 6 weeks in, and you're at a level 2 trauma center. You have no cardiothoracic or ECMO capabilities. Are you going to the OR, or are you transferring this kid? Hey, Marion. That's pretty definitive. So that's what we did. So we got some imaging. We transferred the kid to a level 1 trauma center. We now have a question for you guys about rigid or flexible for taking this thing out. Super interesting. So comments. Who goes flexible?
Kitty, we got a comment right here.
Yeah, Brian.
I think rigid scope gives you more opportunities to put more toys in there to really get that thing out if it's stuck, especially if it's been in that long, or to have adjuncts like balloons at the ready. You just don't lose your purchase or your access with a rigid like you would with a flexible, potentially, especially if things go south.
Santor, you trained him. You agree with him?
Yeah, I do agree. So the rigid, in my opinion, is much easier to get the foreign body out. However, in these situations, I would have both. The reason being is that after you go with the rigid, it's really hard to assess the amount of injury and damage that happens with the rigid because everything collapses. So having a flexible after you remove it to kind of assess the damage. One of the things that we really don't know is how do we score these injuries? If the esophagus, there's no scoring of mild to moderate to severe injury in the esophagus. And that's one thing you can do with the flexible is really assess the esophagus better than you can do with the rigid. So I'd do both.
Who said flexible? Let's hear from somebody that said flexible. %14 said flexible. I do flexible. I used to do rigid, and then I thought, what Matt just said, you need to do flexible after anyway, so why not just take it out with flexible? Regan.
I think you, if there's an injury, you do a flexible, you insufflate a bunch of air in the mediastinum, you're going to make them unstable. I do think there is a staging system. It's like 1 through 5 or something, but it's always hard for me to tell. But once I take it out, I don't go to back in to see how deep it is. I get an esophagram and see if there's an injury there.
That's what it looked like, and there's the esophagram. So it looked like there was no extravasation in this case. You can see some pretty significant inflammation and narrowing of the esophagus there. I think we went over this earlier today, but is there anything that you can wash it with? Yeah, we can definitely wash it. You basically wash it with a little bit of vinegar. The OR can get it for you. I think we learned in the earlier session that it's unclear if it really helps or not, but I think the recommendations are we're still going to go ahead and do it. Now here I'm super interested in this. So what about follow-up imaging? So let's say, the kid does well, you don't put a feeding tube in, the kid's eating some some liquids and is doing fine, and you send the kid home. So no problems, goes home on postoperative day number 1. Do we need follow-up imaging in this child that had this button battery in for 6 weeks? So, and there's a chance maybe that some people want to do 2 separate imaging studies, and maybe that wasn't an option on the app, but I would love to hear. So it looks like the majority of people would bring them back to clinic, in probably a few weeks and get an esophagram to see how it looks. But how about some of these other imaging studies? Like, do we need to get a CTA after the button battery's been removed, an MRA? I know I want Matt Santori to comment for sure because I know he's written about this, but anybody else in the audience have comments? Matt, you're up.
So we kind of struggled with this a little bit because we were developing a button battery guideline and a lot of back and forth. And what we kind of landed on is we would do an esophagram within the first 24 hours to look for a leak. But then subsequent to that, the injuries progress, right? So you don't really know what's happening. And the injury could look, the severity of the esophagus is kind of hard to tell. And what happens over time is that these devastating injuries, the TEFs, the esophageal aortic fistulas, those happen late. So anywhere from 2 to 3 weeks afterwards. And so where we landed on is getting an MRI about 2 weeks after the removal to assess for inflammation, any sort of potential fistulas or aortic inflammation around it. Now when we started this, we actually had MRIs at a week, and then we did subsequent MRIs, but we were able to really eliminate that because it didn't really have any clinical significance. So we landed at 2 weeks, getting an MRI, and it's a very focused MRI to look for these potential fistulas or inflammation around vascular structures. The problem with an MRI is it's very sensitive, and so you get a lot of noise with that too. So there's that problem with the MRI.
And how'd you guys land on MRI over CTA? Just the radiation risk, or were there other reasons?
Yeah, it was primarily the radiation risk and trying to eliminate the radiation from that.
Any other comments? Imaging? All right. Next case. So we had some sessions on trauma imaging. I've got a few cases for you guys here. First of all, 5-year-old falls off his bike, no helmet. There was a brief loss of consciousness, but the GCS is now 15. He is complaining of neck pain. Are you going to CT scan his head? 5-year-old, brief LOC. Regan, you going to CT his head? So there's something called a PCARN rule. I think kind of the point of this, I want to make sure that everybody's aware of this. So there's a group called PCARN. It's a huge group of about 20 different pediatric hospitals that are looking at trauma-related issues, and there is this rule. So, this kid, it really can go either way, but I think you can type this into your phone, just go PCARN head rules if you ever find yourself in this scenario, and it is very easy to follow. What about his neck? So he is complaining of neck pain. His head CT is normal. Are you going to scan his neck? You're already going to the scanner for the head CT. Should we just scan his neck? He's complaining of the neck pain. You're going to get an x-ray. You're going to do nothing. You're going to get an MRI. What are we going to do with his neck? Awesome. They were listening. We appreciate you guys coming to the trauma session. I think we're really trying to promote as pediatric trauma surgeons that while it might seem really simple just to get that CT of the neck while you're in the scanner, if your GCS is 14 or 15 and you have a reliable exam, x-ray is really good. So, I think the really hurt kids, feel free to image, but the kids that have the GCS that's 14 and 15, let's try to get x-rays. What about fast MRI? So we talked about this earlier. Do you guys have it? I'm just curious if people have even heard about fast MRI yet. So it's kind of a new technique for MRI that Dr. Jensen and Dr. Castle talked about earlier, where it's a limited sequence, right? So hopefully it's less sedation, less time in the scanner, and a new technology that's going to help in our trauma patients. So looks like pretty close to half of people at least have heard of this, which I think is great. I think more to come on this, guys. Yeah, you got something?
Super intrigued by this, but and I've seen that data, which is super interesting. But if you don't have a neuroradiologist that can look at that in real time and decide if they need to go for the full sequences or they want to see other views, then potentially for patients that have to come from the PICU and all the logistics that go along with that, that's a big trip, and only to have to turn around and go back for additional images. So if you've got the real-time reads in that perfect scenario and that pathway is well established, then that's awesome. It seems like a long slide for a short gain if you have to turn around and go back for additional images. So that's just one thing that, as I've asked our intensivists and our radiologists about, the juice wasn't worth the squeeze for them in the fast MRI, but it's a great idea.
For us, we're actually looking at fast MRI, and I'm sorry I missed the talk earlier, but we're actually looking at it because there's now a big push for contact children of non-accidental trauma to potentially get imaged. And so we're looking at fast MRI as a way to reduce radiation, get a quick scan, and get these kids studied because they're at risk if they're not the index child, the contact children as well. So that's what we're starting to use at our institution. That's where we're finding it a little helpful, have a quicker study, less sedation.
So I apologize, guys. It's a little hard for me to hear, just so you know. I think the audience can hear all the comments, but I personally sometimes can't hear them, so I apologize if I don't acknowledge them. But I know those were both good comments. Okay, so now we've got a kid, this same kid, right? So you did not scan his abdomen, but you got these trauma labs, and the AST comes back elevated at 223. Does that make you want to scan his abdomen?
While that's coming up, I'm standing behind someone who's published quite a few papers on cutting down on imaging in trauma patients. So I'm going to hand her the microphone.
Excellent, thank you.
Yeah, I wouldn't use a CT scan here because you've got a kid with a normal GCS that you can do serial exams on, and I think we've pretty much proven that a blip in one transaminase is not going to be something that we have to chase down. So I would use admission observation serial exams to guide that story. And I'd repeat his hemoglobin and look at his white count, look at his fever curve, look for other peritoneal signs, that sort of thing.
So observe with serial exams. What if he's ready to go home? Keep him?
I mean, I think a period of observation in your ED is reasonable, and check his UA and watch him for a few hours and see what he does. I guess, I can't remember now what he fell off his bike. That was his mechanism, right? So I guess his social circumstances, how far away he lives, all that might play into it. But yeah, I wouldn't be too concerned about that.
Regan, what do you think Dr. Streck would say? He would say scan him. Some people would say scan him. So I think, we're kind of split here. Just an idea, I don't think Dr. Mooney's here from Boston Children's, but he's done some work on contrast-enhanced ultrasound. There's a study going on right now that just closed. Any of the Arizona people or anybody that participated in that want to make a comment? Hey, guys. I think this is kind of cool, right? So the idea is that this is an ultrasound with a little contrast that perhaps would be great in a situation like this. I don't think we're ready for prime time, but just keep it in mind. Okay, guys, now we got a GCS 3T after a high-speed motor vehicle crash. He's got a seatbelt sign on his chest. Are you going to get a CT scan to screen for a blunt cerebral vascular injury in this patient? Controversial topic. Just curious what people are doing. Wow, lots of people are going to look for BCVI. That's great. How about what screening criteria are you guys using at your institutions for BCVI? There's a few out there. So McGovern, Memphis, Utah, Denver. Anybody with a low GCS, or I don't know, and only if neurosurgery asks me.
Hey, what do they use in Utah?
Not the Utah score. So the Utah score is highly specific, but it's not very sensitive, so we've moved away from it recently, and we've moved to the Memphis score if kids have transferred from other hospitals. And then if we have a kid coming from the scene, we're doing something now that I learned from Dr. Jensen. So we're able to do a single contrast bolus and get a CTA of the head and neck, chest, abdomen, and pelvis in these kids that are GCS, less than 8 with a high-risk mechanism. And that's been working for us very well. So, wow, looks like Denver wins out here. I think Atomic wrote a paper that Memphis kind of won out, but I think in general, you can see when we have so many screening tools, we don't really have the answer on this. So hopefully more coming in the next couple of years. I think so. We've hit the cervical spine. A cool thing is if you get the CTA, you can then recon the cervical spine. So if you're able to do that single contrast bolus, you could recon the cervical spine, and so you're saving the kid some radiation. And it looks like a lot of people are doing that, which is pretty cool. What about, are we going to scan this kid's chest, right? So this is a very hurt trauma patient. And I know there's a lot of data out there that we don't want a CT pediatric chest, right? But this is a high-risk mechanism. You're already scanning the head and the neck and the abdomen and pelvis. Do you guys scan the chest or no? I'm curious on the protocols on the no, right? So is that you scan the head and the neck and then skip the chest and then do the abdomen and pelvis? Anybody want to speak up on the nose in a high-risk mechanism? Romeo, what do you got?
I would get a chest x-ray first. If the chest x-ray doesn't show any major abnormalities, that I'm going to intervene. Now, obviously, I think this kid's going to have a bad pulmonary contusion or maybe a pulmonary laceration. Then I get a CT scan. But if that chest x-ray is normal, I don't know.
It's normal?
Yeah.
No chest? So Romeo, scan the head, the neck, and then the abdomen, pelvis?
That's correct.
Okay. Is there more coming from Aaron Jensen, but is there a role for whole body CT scan in pediatric patients at your guys' hospitals? Or is that still just a pan scan? Is it every now and then does a kid get a whole body CT or no? So a lot of people trying to save radiation, which I think is great. Okay, last case, guys. Last case we're going to talk about today is choledocholithiasis. We've recruited some experts to stay in the audience. I want to tell you guys about a 12-year-old female who is obese, and she comes in with right upper quadrant pain and jaundice. She's got an ultrasound, which looks like there's cholelithiasis, and her common bile duct is dilated. Let's say it's dilated to close to 1 centimeter. Her bilirubin is 6. What's your next move? Are we going to get an MRCP? We going for an ERCP? We're going to do a lap chole, no IOC, lap chole, IOC, and then get a postoperative ERCP if needed? Or are we going in for the common bile duct exploration? So it looks like still 50%. 50% are going to go for the ERCP first.
Katie, we got a hot take over here.
You got it. Everybody's hot over there? Let's do it.
We're ready. We were discussing this before. I'm going to do a lap chole, IOC, and intraop ERCP. So I'm not going to delay it. I've got a general surgeon that does it for us. So it makes it really easy and clears the duct every time. But Luke has some other thoughts.
I think the data speaks for itself. If you have those resources, that's great. I mean, after hours and long holiday weekend, that's just not going to happen most of the time, right? And he has the benefit of a fellow colleague in surgery that's super interested in doing that stuff. That's not ubiquitous. So I think go to the OR, see what you see. Dr. Ignacio and the Webster folks have come up with a duct score. So she was high risk for choledocholithiasis based on that, and the ultrasound obviously showed it. So go see what you can do. There's some, it sometimes doesn't take much to get the duct cleared. And if not, then at least you definitively know that you've got a stone that needs an ERCP and you don't have to jack around with MRCP and all of the lab draws and all those kinds of things that typically, are used sometimes as stall tactics, honestly, just to get a convenient time in the endoscopy suite for them to do what they want to do.
Hey, Luke, what's the learning curve for getting really good at laparoscopic intraoperative common bile duct exploration?
I think if you're a good cholangiographer and you recognize things like the angle of position into the cystic ductotomy and just are thoughtful about how you set things up and maybe don't rely on your operative ports to put that stuff in, then it can be pretty easy. I think Dr. Russell just did one and had a great time, and she really enjoyed it. She can share her experience with you, but I think, keeping it simple is the name of the game. And the more you get comfortable with cholangiography and the more we expose our trainees to that, because I think that's a lost art, or it's a dying art, then this is not really difficult.
So this slide, it's meant to be able to click all. I don't know if it's going to work, but so you see this stone, you're in the OR. So are you going to close and get the ERCP? Glucagon, you're going to power flush. Let's say if you can't click all, can you guys click all? Anybody give me a symbol if it's working? Do the most that you would do, right? So we can flush it, you can put a Fogarty, you could get a choledochal scope out, or you could do this really cool thing that I just learned about from my colleagues in the room here. Put the wire down and try to balloon dilate the sphincter and see if you can get these stones to drop. Let's see what people are up to right now. So yeah, good range. I think that people are trying at least looks like at least power flushing and putting some glucagon. People are doing Fogarties, so I think this is great. I love this quote. This is, from Dr. Neff, Dr. Ignacio, the whole kind of team working on this, but let's reclaim the common bile duct. And I just learned about this, so people who haven't heard it, you can put a wire down into the duodenum, and then basically the same balloons that you use for an esophageal dilation don't go bigger than the size of the common bile duct, but you can dilate the ampulla of the sphincter, and then potentially these stones will drop. And everyone who's actually doing this kind of consistently says it's super effective. We had an abstract earlier today, right? And the point here is, if you're considering choledochal lithiasis, what decreases your length of stay? Endoscopy first or surgery first? And that's right, it was a plenary session. I think these guys have shown, now in a multi-institutional manner too, right? Multi-institutional, we've seen that if you go to surgery first, even if you just do the gallbladder and back out, these kids are staying in the hospital for less time. You can also, you can just do the gallbladder, you can see a stone, you can actually discharge them and they can come back for their ERCP. So there's multiple things you can do, but I think that there's some momentum to surgery first. And then I think this is my final question, but based on all this kind of pretty cool new data on choledochal lithiasis, are we going to change practice? Are we going to try to do this and see what happens? Romeo, duct score, Dr. Neff, I think this is pretty cool. This is pretty cool data. I think a lot of people are kind of being influenced, so good work, guys. And with that, that's going to end our roundups for the day. Thank you, guys. That was some serious resiliency. Thank you guys so much for sticking around.